Good afternoon, ladies and gentlemen, and welcome to the RENEURON Group PLC investor presentation for the preliminary results for the year ended 31st of March 2021. Throughout this presentation, investors will be in listen-only mode. Questions are encouraged and can be submitted at any time via the Q&A tab situated on the right-hand corner of your screen. Simply click Q&A, type in your question, and press send. The company may not be in a position to answer every question received during the meeting itself. However, the company review all questions submitted today and publish responses where it's appropriate to do so. These will be available via your Investor Meet Company dashboard, and you'll be notified once they're ready for your review. I'd also like to remind you that this presentation is being recorded. Before we begin, we'd like to submit the following poll. I'd now like to hand you over to Olev Halibo, CEO, Dr. Richard Beckman, CMO, John Hawkins, Financial Controller, and Sean Stapleton, VP of Regulatory Affairs. Good afternoon to you all.
Thank you very much. Good afternoon, and I answered yes on that poll question. I think there will be a lot of people saying that. Before we dive into the results of the last financial year, I just wanted to start with the great news of the day for us, which is that we're back on track with our clinical trial in retinitis pigmentosa. So it probably gets a bit buried on all the news from our results press release, but that's the latest news, and we're very happy to be back on track with that program. So with that, I'll lead you through the presentation together with the team, and we have some pre-submitted questions that we will get to in the end, and then we'll take the live questions as well. So just as a warm-up for the people that don't know us that well, so we're obviously a cell therapy company based in the UK and in the US. We work mainly with retinal and neural stem cell therapy platforms. Everything we do is allogeneic. That means it's off the shelf with a large commercial potential. The lead program is in retinitis pigmentosa, and Rick will take you through that much more detail. We have very, very good phase 2 data already in hand for that program. We have decided to expand on that clinical trial, and that expansion study is ongoing, so we'll get more data on that in a second. The exosome program is ongoing mainly in collaborations. We have a couple of mainly in collaborations with large biotech/pharmas. We have a couple of collaborations also with academic institutions, and we'll go into that in a bit more detail. And of course, we did a fundraise at the tail end of last year that garnered £17.5 million. So that has given us the opportunity to deliver on a very exciting program. There's a lot happening over the next 6 months for RENEURON, and it's great to have a good cash cushion to deliver all of that. So these are the platforms that we're working on. Human retinal progenitor cells are the lead program. As you know, we are delivering these subretinally. And we have a cryopreserved formulation, which is very important because it not only allows us to be able to create bigger batches, but we can ship anywhere in the world in a cryopreserved formulation. These are shipped in shippers, cryo shippers, kind of look like scuba tanks that have 10 days of dating, so you can really ship it anywhere in the world for a clinical trial and commercially. You can get stuck in customs for a couple of days, and it doesn't matter. And that just makes life a lot easier. It is not an easy thing to do, and so we're very happy that we have solved that. The data we have so far is positive, and RP. There are obviously other indications we can pursue, but RP is what we're focusing on right now. We have a partner in China for this program, and other than that, we are unencumbered. So we have a lot of opportunity going forward there. Exosomes are coming from our neural stem cell. So we have obviously a GMP stem cell line in CTX. So these exosomes have been in man already and giving us a great starting point. We've proven that we can load them with sRNAs, mRNAs, and proteins. We've shown that we can get them across the blood-brain barrier, which is not an easy task, and there's a lot of demand for that. and we're working with them as really a drug delivery vehicle for gene therapies with other companies. The iPSC platform is a newer one, and we haven't talked that much about it yet, but I very much one for the future. So these are pluripotent stem cells rather than multipotent, meaning that we can make any cell really from an iPSC. We can engineer them, and when we do that, we're preserving the immortalization that we had as a starting point. And the immortalization means that we can go to much higher doublings, meaning much higher quantities when we produce them. And that's one of the big issues for other companies in that field. It gives us the potential to create such wonderful things as allogeneic CAR-Ts. And we're also working on pancreatic islet cells for diabetes. Last, the CTX program. So we have, as you know, stopped the program that we had ongoing with CTX last year, and we're now pursuing that purely with partners. And we obviously have Fosun Pharma in China for that. So in terms of pipeline, I'm going to flash this up for you. The next milestones on the right is kind of, this is a good chart and kind of to keep track of where things are going. For HRPC is very much about finishing the expansion study, and we'll talk more about that. Obviously, subject to the data supporting that, we will go in then to a pivotal study late next year. So second half 2022 is the starting time for that. That will run about 2 years for recruitment and garnering the 12-month data for that study. Exosomes is all about working with these collaborations, getting the right proof of concept data that will then lead to a licensing deal. In all these instances, we have collaborators who obviously would like to have a new program, and they are much, much larger than us, so they're pretty clear that they will take it forward. Otherwise, they wouldn't have gone into this collaboration in the first place. For iPSC, the next step is about proving that we have a new platform here. So more on that in the near future. And CTX, I mentioned, China is working on it Fosun is working on that in China, and we're looking for other partners outside China. So that takes me to the highlights for the last financial year. So for the retinal program, as I mentioned, we've observed clear efficacy signals over those 12 months in that study. And we decided to expand the study with an additional 9 subjects. We made a number of protocol changes, and maybe the most important one of those is that we have doubled the dose from 1 to 2 million cells, hoping that we can see even better efficacy going forward. What we've seen that some patients have really excellent efficacy, and some patients have some efficacy but much less. And we'd like to see if doubling the dose is going to push those people that are on the lower end all the way up to the high end. The study was suspended temporarily because we had a serious adverse event due to what we think was a bacterial infection. We've done all the investigation around that and been able to restart the study. It's restarted in the US, and in Europe there is a regulatory step, which is that we need to file an application in the UK and Spain to reopen. I believe we filed that one in the UK yesterday, and we'll file Spain tomorrow. So that's very much imminent to restart that in those countries as well. For Exosomes, last year we signed a number of agreements with major companies. What's great about this is that it generates data for us without us actually having to pay for it. So these companies send us their targets, their payload, let's say, and we work on loading them into the exosomes, and then we send them back to the partner for them to test in the lab and in animal studies. It's not just a one-way street. There is a lot of back and forth in those kind of collaborations where we're trying to, improve and make it as good as possible. We already have data from those, and we've shown that we have efficient loading and functional delivery of exosomes. and now we're working on getting the efficacy rates higher and higher. For the iPSC program, we'll come back to that, but we have created new cell lines, as we already alluded to, both in cancer as well as diabetes. Couple of other highlights, more operational, for the last financial year. For CTX, we decided to stop the program that we were running in order to focus our resources on the ophthalmology and the exosome side. Fosun is continuing that program in China. In terms of board, we announced last week that Ian Ross has been appointed chairman. And we are absolutely delighted to have Ian Ross around. He's, as you know, a very, very experienced operator when it comes to biotech in the UK. We're really delighted that he accepted the offer to join us as chairman. In terms of CFO, we're in very good hands with John Hawkins, our controller, but we are recruiting a new CFO, and that's going very well. But in the meantime, thank you, John. You're doing a great job. Going on to the financials, and I'm going to hand over to John in a second. I mentioned already the fundraise for last year. You can see here that the decision to change our priorities has resulted in a big saving in terms of cost, and we see that already in this financial year that's passed. And we're sitting on a very healthy bank balance, which is obviously helpful, so that we can deliver on all of these opportunities that we have in front of us. And with that, I'm going to hand over to John.
Yeah, hi there, everyone. Thanks, Olav. Yeah, I'm pleased to be able to take you through a summary of the results for the year to March 2021. I'll take you through the items line by line. I won't go into too much detail, but there is a lot more detail in the preliminary announcement that was released this morning. So as you can see there, the revenues for 2021 are materially lower than they were in 2020. However, it should be noted that 2020 included a 6 million upfront license fee from Fosun Pharma. So the 0.3 million this year is purely royalties and also income from research collaborations, and no milestones included in that figure for the year, hence the reduction. And as Olav just mentioned, in relation to the costs, you can see there a significant reduction across both research and development and also general admin, a total reduction in all of just over 7 million. And that reduction does follow the review of our sort of programs and also the associated resource linked to those programs. So that then takes us to an operating loss where the actual reduction in that loss isn't as great as the costs would suggest because of the income, but nonetheless still a reduced operating loss for the period. In terms of the net finance expense and income, I probably ought to explain what that is, because that does show a material swing from one year to the next. The main contributor to that line is foreign exchange. So we hold our cash in both dollars and euros to cover our spend in those currencies. As you can imagine, a lot of our spend is in US dollars because the RP study has been taking place over in the US until recently. So we try to hold cash in the foreign currencies to cover around about 12 months worth of spend. Now, in this past year, sterling strengthened against those currencies, hence we suffered a foreign exchange loss, and that was the opposite in the prior year, where we actually had a foreign exchange gain. Just below that net finance income, you can see the line taxation. Being a research and development company, we do benefit from being able to claim R&D tax credits. It's a nice cash income stream for us, and the amount we received, or we're due to receive for this year just gone, is a little over 2 million. Last year's figure of 2.4 actually also included a 0.6 million of overseas tax. So the the underlying R&D tax credit in 2020 was actually 3 million. So the reduction this year is linked to the reduction in the research and development costs, as you would expect. So then taking us to the cash. So you can see we've got a net increase in cash this year of just under 10 million. That does obviously include the 16.2 million net of cash received from our December fundraise. If we take that cash out of that movement, then we had a burn of just over 6 million, which is significantly lower than the burn seen in the prior year of just under 14. So that's left the company in a very strong cash position at the year end of 22 million. This provides us with a runway of at least 12 months from today, which should enable us to reach some very important milestones across our programs, over that period. So we are in a very healthy position, and that brings me to the end of my chat around the numbers. So I'd now like to hand you over to Rick, who will discuss our lead program. Thank you very much.
Thanks, John. So let's talk about retinitis pigmentosa and the unmet medical need. RP is an inherited retinal disease. It's a devastating disease. It probably affects 1 in 4,000 worldwide. In the US, that's about 100,000 people. And in the UK and the EU, about another 150,000 people. What's bad about this disease is it starts early on, maybe in the teens or early 20s, and the patients start to notice that they're losing their night vision. And then as it progresses, they start to lose all their peripheral vision as their rods degenerate, the rod photoreceptors, and they get something known as tunnel vision, which you can see in the slide. But the worst thing that this disease does is after that, all that has gone on, it then attacks their central vision, and they lose the ability to read and to navigate and to drive. And that happens around the time when they're at the peaks of their lives. So they've known that they have this devastating disease for years and years. And up until very recently, there was no hope for any type of cure. You may have heard about Luxterna, which has just been approved in the last 2 to 3 years as the first gene therapy for retinitis pigmentosa. There's about 100 different genes that we've discovered that affects and results in this condition. And Luxterna probably treats about 1 to 2% of those patients. There's multiple companies that are looking at different gene therapies, and each of those would address low single digits. And so we're very, very happy that what we're doing is a retinal progenitor cell therapy that we believe is agnostic to the genetic type. And therefore, we believe that we can provide a potential cure for patients who have all different types of genetic mutations, which opens up the market significantly, but it also allows us to help the lives of many more individuals. So just exactly what are these human retinal progenitor cells? They're stem cells that have already differentiated down the pathway of becoming the neural elements of the retina. And so these cells can become the rods and cones, which are called the photoreceptors, and they can also become some of the structural components and connections necessary for sight. We've shown in animal models that these cells can differentiate in the retina and become new photoreceptors and regenerate photoreceptors and make the connections. We've also shown that by integrating in the animal model that they could become a durable source of trophic support for dysfunctional retinal tissue. We believe that this technology can address a wide variety of retinal conditions. However, we're working right now on retinitis pigmentosa. We have orphan drug designation in the US and in the EU and UK, and we also have fast track designation in the United States. The cells that we're using are the results of a research collaboration between the Scape and Eye Research Institute, which is part of Harvard in Boston and University College in London. Our proprietary technology and the experience of RENEURON in working in stem cell therapies has allowed us to make the step of developing a cryopreserved formulation, which Olaf alluded to before, allows us to treat patients at the site where they're being seen by their physician, as opposed to having to transport patients all across the country or across the globe to a center which is treating patients with something that is not cryopreserved and only has a shelf life of about 16 hours. We believe there's a large commercial potential on the basis of this cryopreserved formulation, and also because our mechanism of action is independent of the genetic type involved. So our clinical development started about 4 years ago at Mass Eye and Ear Infirmary in Boston, where we did a single ascending dose study for our phase 1. We started with a 250,000 cell dose of fresh cells. We went to a 500,000 cell dose of fresh cells, and then we generated a cryopreserved version, and we went to the 1 million cell level. These were patients that didn't have any real visual potential, and such it was a safety study. But what we did is we demonstrated adequate safety to move on into patients that had better visual potential. And that's what the phase 2A study started off. We've treated 10 subjects in that study. These are patients with better visual potential. This is with the 1 million cryopreserved cell dose, and we've shown a very good safety profile. And we've shown a very early but strong signal of efficacy, and I'll show you a little bit more about that. The 2A study, we expanded into an additional site, the Retinal Research Institute in Phoenix, in addition to Mass Eye and Ear Infirmary. This is showing the injection technique, and I'm not sure if I can get that. Does that, well, if not, what you're doing is you're actually looking at a picture inside the eye, and that little brown cannula is injecting cells underneath the retina. We believe that the anatomic placement of the cells underneath the retina is very important, because cells being placed in that area can therefore integrate into the retinal structure itself and can do two different things. One, as I mentioned before, they can differentiate into new photoreceptor cells and make the connections necessary for sight. And the other thing that they can do is they can serve as a durable reservoir of trophic support or nutritive support to the cells that are degenerating there. This is showing you the data from 1 year of those first 10 subjects. You'll notice that we don't have a complete data set. COVID has made it difficult for patients to return to some of their appointments. However, what I'm going to show you in this data is very important. If you look at the light blue line on the graph, that represents the mean change in visual acuity for the treated group across the different time points. Down below that, the dark blue line represents the mean change in visual acuity in the untreated patients as a comparator. And what you can see is those lines separate very early, and the treated patients maintain between an 8 and 10 letter gain in visual acuity out at 1 year. A 10-letter gain is a visually and clinically significant improvement in vision, especially in a disease of retinitis pigmentosa, where left alone, patients will continue to lose vision over time. And we believe that this is a very important thing. What you're looking at right here at day 365, I'm going to show you in a little bit more detail in the next slide. And there's two real take-home points from this slide. One is that the mean change in visual acuity at 1 year, we believe, is an approvable endpoint in the US and in the EU and the UK for a treatment for retinitis pigmentosa. The second point, as you can see on the right, some of the patients had a very remarkable response. And you can see on the left that some of them have had a lesser response. And so in drug development, when you have no dose-limiting toxicity and you have a variability in the clinical response, the first question that you want to answer is what would happen if I increase the dose? So instead of going for a regulatory approval pathway on the basis of the 1 million cell dose, we decided to stop and go into another cohort of patients where we actually double the dose. And so we designed the phase 2A extension study, which I'll talk about a little bit now. That's the study that's ongoing right now. We went from 1 million to 2 million cells. We also added microperimetry, or a measure of retinal sensitivity, as an additional way of looking at efficacy. Visual acuity is well established as a functional measure of efficacy, but the sensitivity of the retina at each different point has been shown by Nightstar to be a very valid method of showing functional improvements in efficacy. And so we added that as an additional endpoint, and we select out patients that are capable of doing that test. We've also done a modification of the surgical technique, which is important. Initially, we decided that it was appropriate to inject the cells right underneath the functioning retina. That can have a double edge to the sword because you're actually elevating the retina away from its nutritive blood supply. So what we decided to do in this is we now do injections that are carefully planned by a committee of our investigators before surgery to be able to put the cells in an area adjacent to the functioning tissue with the idea of not exactly lifting off the functioning tissue. We added additional sites because we wanted to expand into the UK and into Europe. We added Oxford Eye Hospital with Professor Robert McLaren. We added an additional US site, KCI Institute, and we added a site in the EU in Barcelona, Spain with Dr. Jordi Moniz as the investigator. So where are we right now? The next steps is to continue with recruitment in the phase 2A extension study. As Olaf mentioned, we had to temporarily suspend enrollment because we had an unfortunate incidence of a severe bacterial infection. There is a known incidence of those type of infections in any type of eye surgery. It doesn't make it easier to take. However, our Data Safety Monitoring Board and multiple meetings of our investigators felt confident that this was what the cause was, and they have given approval for us to move forward. We've already started up enrollment is able to be done in the United States, and as Olaf mentioned, amendments are being submitted this week to allow us to restart the study. The good news is we still feel that we're on track to have data on these 9 patients by the end of this year. We hope to be presenting it at a major ophthalmic meeting sometime this fall, and we look forward to moving on into a further clinical trial, which we believe will be a single study. That would be a pivotal clinical trial, the design of which we've already discussed with the FDA, and it's well known to us. In this type of surgery where you actually inject cells under the retina, you really can't do a placebo group because it's too invasive to have to inject underneath the retina. You're not going to want to go into somebody's eye and inject saline. So the way that these studies are done is you have 3 different groups. You have an untreated control group. You have a low dose group, which is ideally designed to be a dose that's probably lower than you would want as your clinical dose. And then you have your high dose, which is probably the dose that you're going to achieve the results with. And this is the standard design, probably about 100 patients or so. And we hope to be able to kick off that study by the end of 2022. And a last brief slide just to show you that other people are playing in the sandbox that we're in right now, inherited retinal diseases. The only really direct competitor that we have in using human retinal progenitor cells is a company called JSight. However, there's a couple notable differences between us and JSight. While they're injecting human retinal progenitor cells, they do it into the vitreous, into the center of the eye, and therefore they have no ability to have cells integrate into the tissues of the retina and to regenerate and have differentiated new neural photoreceptors. The other thing is JSight does not have the capability of generating a cryopreserved formulation, and so all of the patients that have been treated in their clinical trials have to fly across the country because they have about a 16-hour leash to get their fresh formulation of cells. Looking at the other companies out here, you have Spark Therapeutics, which we know has been very successful and was acquired by Roche a couple years ago for a very large amount of money. They also have other gene therapy programs. Nightstar was acquired by Biogen. They're working in the same space. And then you have AGCT and Myra GTX, which are both going after single mutation diseases and retinitis pigmentosa. And then ProQR is another very interesting company, which instead of doing gene therapy, they're actually using RNA therapy to fix genetic defects. And we hope that all these people are successful. I think that the big point here is that aside from JSight, they're going after specific genetic mutations, and we believe that the real answer is to be agnostic to genetic cause. I think that's all I have, and I'll turn that back over to Olaf.
Thank you, Rick. Yes, I wanted to spend a very short time on the exosome program, since really the retinal program is the most important. But the kind of quick recap on exosomes. So these are naturally occurring delivery systems. So these are nanoparticles nanovesicles, and we hijack them as a delivery system, and it's natural occurring. So there's a lot of research going into using exosomes that way, and it's a pretty hot area for research. We are lucky that we've been working on this for a while. We've seen favorable distribution across the blood-brain barrier, but we're able to engineer them to target any tissue in the body. We have proven that we can load them. We've proven that they're stable, and we can have consistent high yields. We have very good analytics behind it, which is more and more important here as the regulators get involved. I mentioned in the introduction that we're working with collaborators with very significant programs, and we have co-development or co-rights for any program that we develop here. So, obviously, the payload and the truck together creates a new entity, and we own that entity 50-50. If we show a proof of concept here, our expectation is that the other company will license our rights so that they can take it forward into clinical development. And in all cases, they are much, much larger than us, and they wouldn't start these programs if that wasn't their intention. I wanted to share with you, though, some of the potential value realization that we can take advantage of here. So on the right-hand side on that slide, you see the 4 recent exosome deals. So Kodiak and Evox are the 2 leading companies in the exosome field. They're all fully dedicated to exosomes, and they're both signed a couple of very significant deals each. So just to give you something to kind of compare to. And also for our retinal program, Rick mentioned JSITE. JSITE is a little bit ahead of us. In that they're in a 2B study, and they have delivered some data, and the data is strong enough for a deal of the size that you can see here. They got $50 or rather $62 million up front, and that is for non-US rights only. And the value of the US rights is much higher than the international rights. And I know Santen wanted everything, but JSITE did not want to get rid of the US rights. So I think it's a very credible deal for a company that we're quite similar to in many ways. So we know what we're working towards. So I wanted to summarize the opportunity before we go into the Q&A. So yes, there are absolutely major value creation opportunities for us for the coming year, both for HRPC and for the research platform. And we're well funded that we're able to actually get there and deliver on this. The exosome program is being advanced in a partnering fashion, while obviously HRPC we're running ourselves. The data, we'll have more data later in the year, but the data we have already compares very, very well to what else is out there. So with that, I think we will I'll hand over to the operator for the questions that have been sent in advance, and then when we're done with that, we will go to the live Q&A.
Fantastic. Thank you indeed. Olive, Rick, John, thank you very much for the presentation. Ladies and gentlemen, do please continue to submit your questions using the Q&A tab situated in the top right-hand corner of your screen. But just while the company take a few moments to review those investor questions submitted already, I'd like to remind you that the recording of this presentation, along with a copy of the slides and the published Q&A, can be accessed via your investor dashboard on the Investor Meet Company platform. I'd also like to remind you that your feedback is important to the company, and immediately after the presentation has ended, you'll be redirected to the opportunity to provide your feedback in order that the company can better understand your views and expectations. We have received a number of pre-submitted questions, you said, Olaf, and perhaps the first one I can address to you, if that's okay. It reads as follows: where are Fosun with their CTX trial?
Thank you very much. Yeah, so Fosun is concentrating on tech transfer or manufacturing for both CTX and HRPC, so that's what they're working on. They're very much committed to CTX for China, even if we have stopped the program in the US. So they're very much committed to that program. Stroke is a huge commercial opportunity in China. It's a very large indication there, maybe due to very high smoking rates. Fosun is very much behind that program.
Fantastic. Thank you very much indeed. The next one, if I could address to Dr. Beckman, does dose amount affect the cost of an injection, and is the delivery dose expected to change over time?
So the answer to that question is that currently the vials that we manufacture for the clinical trial hold enough for either 1 million or 2 million. So there's been no effect on the dose volume in terms of the cost. As we determine exactly what the dose that we're going to go for approval on, then we will probably modify things to make it the most cost-effective way of doing that. And then the question is the dose going to change? I don't know. It's possible that we might end up going with the 1 million cell dose because, as I showed before, we think that the efficacy is at the level that it would render an approval possible. However, we still don't have the data yet on the 2 million cell dose, and so I'll hold judgment until that time.
Thank you very much indeed, Dr. Beckman. And Olive, the final pre-submitted question is: we've received a number of questions around the Exosome program. How long do you see these collaborations lasting? What have they shown so far, and what's expected for the future?
Yeah, thank you. I see there are a number of questions on the live Q&A as well on exosomes. I'll try and kind of answer as many as I can in one go. So yeah, research collaborations do not have necessarily set timings, or if they do, they typically roll over. They kind of, year on year. We follow the science, and that involves a lot of back and forth between the two companies because we work together to achieve the optimal characteristics of the loaded product. So it's not kind of just a one-shot kind of thing. It's very much a back and forth, which is what the collaboration is all about. So we have already shown proof of concept in terms of functional deliveries with sRNAs and proteins with our exosomes. So a lot of the proof of concept that we set out to achieve, we have done already. We are, however, not happy yet with the efficacy levels. So that's why you haven't seen many presentations or publications on that, because we think there's still more to be done when it comes to increase the efficiency of the payload binding, improving how the payload is released in the target cells. And we can do that by modifying structures. And we can also use peptides to target the tissue so that we can get better loading of the loaded exosome product. So there's still a lot of work ongoing on that. I have a question from Pavel about why we rescheduled the proof of concept delivery from Q2 to Q4. And, it's kind of half true that we've done that. We did have the proof of concept already, but we'd like to improve on it and refine it more. So we'd like to keep pushing those programs forward with our collaborators. So I hope I answered a lot of the exosome questions there.
Fantastic. I think you have there, Olive. But if you wouldn't mind just clicking on the Q&A tab, and we have got a number of other questions that have come through, and perhaps just if you could read out the question, even who it's from, and either direct it to the team or answer it where appropriate to do so, that'd be fantastic. Thank you.
Yeah, Nick D, I think we answered that one. Nikki H asks about the listing on the NASDAQ for the next 2 years. And, it's difficult to answer, obviously. I think we like to achieve success in the UK before we achieve success in the US. I do know that all successful European biotechs do want to have a NASDAQ listing, and we want one as well. But I think it's important to do it when your market cap is at the right level. I think a successful IPO in the US is between $50 and $100 million in financial raise. And most of them are targeting 100 million. So you obviously need to be of a decent market cap in the UK, I think, before you take the step to NASDAQ. Pavel, I think I answered that one. Also from Pavel, when do we expect next milestone payment from Fosun? I'll try and answer it, John, and then you can jump in if you want. But I think the next milestone payment is linked to completing the current HRPC study that's ongoing. I don't know if we ever have made public what this milestone is. but that would be the next milestone payment. Mohammed asked why we buried the news about the restart of the trial in the results RNS, and I think we didn't do that on purpose. The two things happened to kind of coincide in terms of timing. So if we didn't have the results, we would have just done the RNS on the restart of the study, and we combined it into one. And I agree. I think probably that's drowned a little bit. And in retrospect, maybe we should have had two RNSs side by side. So I kind of agree with you that it drowned a bit. Although I think that people have noticed, and we will let the market know, further as the trial progresses. The important thing is that we're back on track for the program. Rick, would you like to talk? Would you like to answer the question from Robin D on more details around the 1SAE?
Sure. Thanks for the question, Robin. Do we notice any minor variations, deviations to the recommended procedure in the patient who suffered the presumed infection? The answer to that is no. We did an extensive investigation. As you're probably aware, there is some background rate of endophthalmitis in any type of surgical procedure. With a vitrectomy, the rate that's generally quoted is about 1 in 3,000 cases. However, that's a vitrectomy without a subretinal injection of cellular material. And so we did a very extensive investigation looking at the batches that were manufactured, any of the steps in the mixing procedure, and all of the steps in the operating room, including going through all the equipment that was used. And as is not uncommon in these type of cases, there was no smoking gun. The diagnosis of bacterial infection was based on the timing of the occurrence, the nature of the eye, and the rapid response to intravitreal antibiotics. We work with our investigators. We work with our DSMB extensively and had multiple meetings. I've had multiple conversations with the chairman, and we found no smoking gun, and we found nothing lacking in the procedure that was used. However, like anything else, what you do is you go back and you say, is there anything that we might have done better or might have done different? And so we do have some recommendations that we've standardized that are going into the protocol amendment. One of those has to do with providing prophylactic antibiotics, mandating the use of that. Some surgeons do, some surgeons don't. In this clinical trial now, they all will. We've actually moved the mixing of the cells and loading all into the pharmacy. It used to come in a vial out to the operating room, and then they would withdraw them in a syringe and put them into the installation machinery. Now they're going to come out of the operating room in a syringe. We have no reason to believe that there was any contamination that occurred, but you never know. So we've done all of the extra due diligence on what happened in this particular procedure, and we've made some modifications consistent with trying to make it even more safe. Whether that's going to make a difference, I think it's just an unfortunate occurrence. I think the most important point is that we are going to be enrolling more patients. We do have a 3-month cutoff. Whether we'll get all 9 patients with 3 months data, I'm sure aiming to be able to do that. Some of it's going to be up to the regulatory agencies. In the UK, it ought to take about 35 or so days. Spain a little bit longer. Sometimes they'll help and move that along even more quickly, because I can tell you that our investigators are very much interested in getting restarted.
Thank you very much, Rick. I'm going through the list of questions. I think there's some other questions similar to what you just answered. I have a question about shedding more light about the search for the new CFO from Marcus. All I can say is that we've had excellent candidates that we have found and interviewed, and we're just in the process of signing the dotted line with our preferred candidate. So it's looking great, and we're looking forward to having the new CFO in place. Question about how important Ian Ross is to the company, given that we're on the cusp of securing commercial deals, from Marcus as well. And I think Ian will really add a lot of value to us. I'm working very well together with him, and he has a lot of experience in securing deals for UK biotech. So I think it's great to have him on board. I have a couple of questions around when do we expect exosome collaborations to turn into licensing deals, and we expect, hope/plan on get the proof of concept in one or more of the collaborations that we have ongoing. Obviously, not all of them will lead to that. So that's a kind of a Q4 aim to have that done. After that, we expect then that to lead into a licensing deal. That usually takes several months to negotiate. So I think that you should think about that as being kind of Q1 next year for a deal. But this is obviously complete speculation. But just to give you some potential timelines around it, there is no deal before it's signed. Sorry, I'm gonna need to read these questions at the same time here. There's a question around exosomes and cryopreservation, and actually we don't. You don't need to have cryopreservation for exosomes. Exosomes are actually cell-free; they're not cells. They're manufactured in cell media, but they're actually not cells, so you don't need to have cryopreservation for them. So it's a lot easier to deal with.
I think, Olaf, you've pretty much covered off every question that we've had through. So thank you to you and the team for being so generous with your time. And of course, any further questions that do come through, the company will be able to review and post responses where appropriate to do that. So, Olaf, perhaps on that note, if I could just ask you for a few final words just to wrap up, and we'll redirect some investors for some feedback for you.
That's great. Yeah, thanks everyone for your attention. Wonderful that so many people were able to attend today. So thanks for your interest and your support. And yeah, I think in summary, we're delighted to be back on track on the RP program. We have a lot of interesting data to deliver over the next 6 months. So we're extremely busy here, and we're very excited about the future. Thanks again.
That's absolutely fantastic. Look, thank you very much indeed, Dr. Beckman, Olaf, John, Sean, thank you very much indeed for updating investors today. Can I ask investors not to close the session, as you'll be automatically redirected for the opportunity to provide your feedback in order that the management team can better understand your views and expectations. This will only take a few moments to complete, but be greatly valued and appreciated by the company. On behalf of the team, thank you very much for attending.